Now we are established and we are convinced that cardiac resynchronization therapy has a definite role in patients with heart failure and wide QRS complex. And there are data which are shown time and again for years together, more than 25 to 30 years, it has been confirmed. And this is the data right from 2006 and further down till yesterday, it confirmed that this is a very, very effective therapy. But if you look back right from Miracle trial, KRHF trial, John Cleland, he was my colleague, we used to work together in the same hospital, and Companion, Reverse, MADIT, CRT, and RAPT. All these trials have time and again proved that it is a very effective treatment, effective modality of therapy in heart failure with wide QRS complex. And it has also shown that it changes the clinical outcome of the patients of heart failure, which in terms of reduction of hospitalization, improvement of survival, improvement of quality of life, as well as the further complications like rehospitalization, which is extremely important. And if you look back further, the other trials, so many of them, the Path Heart Failure trial, Miracle trial, and the series of Miracles trial with Contact CD and Reverse trial, again has confirmed and proved that this is a very effective modality of therapy. And we have spoken about these trials in various occasions, on various forums, and multiple times, many times I'm sure that it has been established. And also, initially, the cardiac resynchronization therapy was intended for severe heart failure like functional 3 and ambulatory functional 4. But afterwards, MADIT, CRT, and other trials have shown that even it is effective modality of therapy in mild heart failure with NYHA class 1 or class 2, which is extremely, extremely important and valuable. Furthermore, the resynchronization defibrillator for ambulatory heart failure trial like RAPT trial and Reverse trial has also confirmed the effect of CRT in NYHA class 1, 2, and class 3. And these findings are reflected in the current Japanese Cardiac Society or Japanese Circulation Society guidelines. But there are certain misunderstandings. For example, if you do a CRT therapy, and time and again the clinician, they think, well, let us look at the data like echocardiographic data, the electrocardiographic data. But amazingly, the correlation between the electrocardiographic improvement and echocardiographic improvement and symptomatic improvement, there is no clear correlation. It has been shown that clinically the patients actually do much better as compared to echo as well as compared to electrocardiogram. At some point, I must say that maybe 10 years ago, and I had a meeting in one of these conferences and proved by data that there is no correlation, and I actually gave up the echocardiography follow-up for patients on CRT therapy. Because the clinical composite score based on response, if you look at them, the functional responder and echocardiography responder, there is a tremendous deviation. The echocardiography responder could be 70%, but the functional responder could be 90%. So at the end of the day, what matters to the doctors and to the patients and their families is the clinical improvement rather than who bothers about echocardiography improvement, who bothers about electrocardiography improvement. It is probably this meeting bothers. But your everyday life doesn't really bank on this echocardiography improvement. But it is important. This is supportive, but not exclusive. Now, coming back to the patients of non-LBBB group, there's a huge controversy going on whether or not to give CRT therapy to this non-LBB group or so-called right bundlement group. And this is a trial from Italy which has shown that patients with right ventricular right bundlement block, we know that there is RBBB in presence of heart failure. But we have to understand, which I actually talked in many times, that this so-called quote-unquote RBBB may have actually sort of concealed LBBB. We have to have that expertise and understanding to recognize that inherent LBBB inside the RBBB, and it has been shown by this group that this subgroup may actually get benefit by CRT therapy, although we have to wait for a longer period of time to get which group will be effective. As of today, we know that the CRT therapy has been suggested for patients with QRS duration with LBB. We know that. We also know that in some studies, like Miracle CD and Contact CD has shown that, yes, some patients of non-LBBB may get benefit by CRT therapy. But MADIT CRT and RAPT also showed that is increased heart failure event-free survival rate in LBB patient, but not in those with right bundle branch block or interventricular conduction defect. So there is a conflict whether or not to go for CRT and RBBB. The question comes, what happens in RBBB with say left anterior hemi block? So, but there are certain electrocardiography parameters by which you can probably think that, well, this group may help. However, having said all this, the reverse trial probably has shown a benefit of CRT among patients with RBBB and mild heart failure trial. So, as of today, as of this afternoon, probably heart failure with a non-left bundle branch block and QRS duration more than 150 millisecond and NYHA class 3 may be considered for CRT therapy. That is my understanding as of today. Maybe it will change tomorrow morning. So coming back to the newer concept of left bundle branch block optimized cardiac resynchronization therapy, LOT CRT group. And I have to say in front of everybody that our centers at the moment is one of the leading centers in this country. Thanks to Shambhuga Sundaram and Dilip, my colleague, they are being very supportive for this program. And we have shown this conclusion, probably not dissimilar to the conclusion that what we found in our data collection. Because the LOT CRT is a feasible, safe, and provides greater electrical resynchronization as compared to biventricular CRT, and it could be an alternative, especially when only suboptimal electrical resynchronization is obtained with IV CRT. Randomized control trial comparing LOT CRT and IV CRT is needed. That is probably which is very important. But limitations of IV, we know that, because there are a group of patients who are non-responders. There are a group of patients with that kind of bald CRT, coronary sinus. There is no area where you can park it. There are situations when they advance, a lot of scars all around, you don't know where to put your lead. So there are a lot of limitations. And again, for some unknown reason, some patients of so-called heart failure and ischemic heart disease or even dilated cardiomyopathy, they do not respond. People tried with imaging technique, with cardiac MRI, with so many modalities. They could not identify that which subgroup will respond and which subgroup will not respond. The Korean group did a phenomenal study on this. They could not even establish that, well, these could be the reasons why they are not responding. This could be the reasons why they are not responding. So we know that there is a difference between LOT CRT and IV CRT, the anatomical placement of the lead, the physiological function, the electrical function, they are completely different. So this could be a mechanism by which the LOT CRT, or even that way his bundle and CRT, may have some edge over the conventional biventricular pacing. But we do not have a properly randomized data to support this, but there are papers which is quite effective. But we have to understand that impact of blood bundle optimized CRT versus IV pacing is interesting. Because if you look at this data, the baseline versus IV CRT versus left bundle area CRP and LOT CRT, it seems that if you really go further down and come to the LOT CRT, statistically, the improvement value is really significant for those patients who are going for left bundle area pacing versus for those patients who are going for the LOT CRT pacing. So LOT CRT definitely has a place, and we need to understand it needs some additional skill, some kind of support with experts, but eventually I'm sure that this particular technology with LOT CRT or left bundle area pacing versus CRT, or even his bundle pacing versus CRT, may have some role about improvement from the clinical point of view. If you look at the cardiac resynchronization therapy, this is a paper which is being published and shown that there's a lot of improvement from the echocardiography point of view, ejection fraction, functional class, and systolic pressure, hemodynamic improvement, functional class improvement, left ventricular ejection fraction. But still we have to wait to have more data to come up to ensure that really in real terms there is a significant reduction of hospitalization, significant improvement of quality of life, significant improvement of the functional status, and the medical requirement, medicine requirement. That would be of extreme importance. If you look at his optimized cardiac resynchronization therapy called HOT CRT trial, which is again a new concept. It's just a little bit more expertise, a little bit more skill, and further advancement of the hardware technology. But if you can do that, it has been shown that in this feasibility cohort, if you really go back, and this is a paper which has been shown by Dr. Vijayaraman, has shown that in this feasibility cohort has shown that some improvement. So if you look at the, there are so many trials coming up with image-guided CRT, advised guide CRT, multi-site pacing trials, optimization of CRT response. So everything has shown that yes, so many trials are coming up. So to conclude, as of today, the CRT is recommended for symptomatic patients with heart failure in sinus rhythm with white QRS more than 120 or 120 and 150. It should be considered, and CRT should be considered for symptomatic patients with the same kind of duration more than 130. It should be considered for some patients of non-LBBB group. CRT should be considered for patients with heart failure in atrial fibrillation with probably in some group of patients. AV junctional ablation should be added in case of incomplete biventricular pacing due to conducted atrial fibrillation. And finally, the superiority of LOT CRT and or hot CRT over conventional BiV pacing needs proper randomization and identification of subgroups before guidelines directed recommendation can be done. Thank you very much for your attention.